So we are going to start our afternoon activities. We will have a series of lectures here in the main rooms, and there will also be the skill labs that are starting simultaneously. So it is my pleasure to introduce Dr. Joe Jarvis. Our introductions have been quite brief, as you may have noticed, and that way we give the maximum amount of time to Dr. Jarvis. But he's been a long-time practitioner both in family medicine and in public health. He's also an author, and we have a number of his books out on the front desk here. We don't have the long signing place that we used to have over to the left, so if he's going to sign the books, it'll be right out here where Teresa is sitting. So we'll turn the time over to Dr. Jarvis. Thank you.
I've been an irregular attender of this meeting over the years and very much enjoyed being part of the audience and am very grateful to have been invited to speak. The topic that I am going to tell you about has to do with this organization, Common Sense Healthcare for Utah. I represent them in making this presentation to you. We are a group or a consortium, a coalition of people all across the state of Utah who are persuaded that our healthcare system is, as I think it was Dr. Morris characterized it, not a system at all. And it is failing us and it's failing our patients, and we want to do something about it. We believe the system is too complicated. We believe that it is at best mediocre in quality. You heard some of that, at least pieces of it this morning, as someone mentioned that there are 400,000 deaths due to medical errors in our country. That would make it the third highest cause of death in the country. You also heard someone refer to the fact that there was a medical device manufacturer who refused to accept a major improvement in its product because they were afraid it would hurt sales. We have a system that's more oriented to taking care of how to make sales and how to make a profit than it is to actually taking care of a patient. In response to that, our group looked at what has been done in our country for 50 years in terms of trying to reform and improve the system. This is referred to generally as incremental improvements, and we've decided that those have completely and totally failed. We are not about incremental changes. We are a group that is determined to bring to the ballot for Utah residents to vote on a substantial and meaningful change in how we do healthcare business in the year 2026. I'm here to tell you today why we think that change is important and how we would propose to go about it, at least as far as we've developed the proposal to date. Please visit our table. We have colleagues of mine will be here all 3 days of the meeting. Out there with the other displays, and as was mentioned, I'll be sitting at the desk out after this presentation where you can purchase a book and the movie that I've produced about the need for health system reform. Okay, technological failure here. Oh, there we go. This slide is one view of how our health system is a failure. For all of us. It's a 50-year slide. It plots the life expectancy versus the personal cost or per capita cost for healthcare in a number of countries across the world. I don't mean for anyone to really be able to see the detail among that big glob of nations and their plot. But I do mean for you to see that there is one of those nations, one of those lines that's not like the other. It starts back in the group 50 years ago when I was graduating from high school, and that nation has had a persistent, rapid increase because this is the per capita cost along this axis, while its life expectancy has not gone up like most of the rest of the world, but rather flattened out. And that, of course, is our country, the United States. We are an outlier by a big margin in terms of healthcare costs. You've already heard it referred to, a $4.5 trillion health expenditure budget in the current year, and that's if it were if our healthcare non-system were a separate country, it would be the third largest GDP in the world. It's huge. It's ridiculously large. Now, I want to quickly say here that life expectancy is not really something that improves dramatically with more and more healthcare. So it may not be the best measure of the impact of health spending. But you've also heard people refer to the fact that if you were to substitute another parameter like maternal mortality or infant mortality for life expectancy, we would have much the same graph. We fail in a lot of ways. Americans get sick younger and get sick more often and die younger than people in the rest of the first world. Changing the measure of the economic amount spent on healthcare from per person or per capita spending to spending as a percentage of GDP is what this slide does. And this is 40 different countries with the mean GDP percent in the red, and all the other countries, again, you can't read the names, it's not important, except to know that the one on the end with the big tall bar that's larger than any other nation's bar in terms of percent GDP on healthcare, that again is our nation. We're approaching 20% of gross domestic product spending on healthcare. Back about 40 years ago, when I was the state health officer or public health leader for the state of Nevada, I attended a Nevada State Medical Association meeting. That was in an era when, for the first time, the US GDP going to healthcare was differentiating itself because it was larger than the rest of the world, and there was an economist who was invited to present to the physicians there. And at the time, the percent GDP going to healthcare in the US had gone to something like 11 or 12%. And he said that that wasn't a good thing, that there was a problem with that. Amongst the physicians in attendance at the meeting, one stood up and said, "Isn't healthcare a good thing? And if it is a good thing, why is it wrong for us to spend more and more on it? Why is that a problem?" Now, I think maybe this is something that you can automatically respond to. I couldn't myself at the time. I thought maybe he was right. But since then, I've heard our former governor here in Utah and former Secretary of Health and Human Services, Mike Leavitt, say there will never be a country that is in the first world that spends 25% of its GDP on healthcare. Now, what he's implying, or I think trying to directly state, is that there's a limit to how much of a good thing we can have in terms of spending, probably not just on healthcare, but probably on anything. If you skew your economy too much in one direction, things start to fall apart. I think that's what he's saying. So let's think for a minute about why that might be a problem. We're now not at 11 or 12% of GDP, but closing in on 20%. What's going to happen? How's it going to unfold if that in fact is not a good thing? In order to answer that, I'd like you to hearken back even further to the time a couple of weeks before Eisenhower retired and was succeeded by John F. Kennedy. In January of 1961, he managed to persuade the big networks to allow him to have time to give the nation his farewell address, and he did so primarily to make a statement about a problem he had seen developing. Now, he's, of course, he was military, right? He ran the Allied military efforts in Europe in World War II. He is somebody who would certainly know that defense spending can be a good thing. But his main point in that address is down into this paragraph. In the councils of government, we must guard against the acquisition of unwarranted influence, whether sought or unsought, by the military-industrial complex. The potential for the disastrous rise of misplaced power exists and will persist. He was saying that even though defense spending is a good thing, we in the United States then were during a prolonged period of peace after World War II, and yet the defense budget was rising dramatically under the influence of a group of people he called the military-industrial complex, who began to concentrate power and influence with Congress and other parts of the government to make sure that their interests were taken care of, which meant buying and selling more weapons. And he thought, and he said this overtly in his address, we will not be able to enjoy a life worth defending if we give our way of life away by spending too much on the military. The spending itself is a problem. Now, there was one country who apparently wasn't listening that night when Eisenhower gave that address. All of this I hope, is in the memory of most of us here. In 1989, a major world power collapsed and fell from the first world really to the second world. The Soviet Union overspent on military. They skewed their economy during the Cold War to the extent that the economy fell apart in the Soviet Union. What is less well understood, I think, by most of us here in the United States was at what level of percent GDP did they collapse that was spent on the military? And it turns out it was 20%. 20% GDP spent on defense spending in the Soviet Union, and they collapsed, their economy collapsed. Now, this observation has caused a number of people in healthcare to begin to wonder if we aren't putting ourselves at risk for the collapse of our economy by duplicating what the Soviet Union did, except not in military, but in medical spending. In fact, Arnold Relman, who was the chief executive editor of the New England Journal of Medicine a few years ago, coined or rephrased Ike's coined phrase and said, it's not the military-industrial complex we need to worry about, it's the medical-industrial complex that we need to worry about. This is the group of larger and larger and larger corporations that seek their profits out of that $4.5 trillion revenue stream swashing its way through our government and through our private sector. They want to preserve their piece of that pie. So how does that end up threatening everything else in the economy? Let's assume that it keeps going and it gets to the level where the percent GDP is closing in on Michael Levitt's 25% limit that he says beyond that there's no first world country. What will happen? Well, to answer that, think back again, this time to the late 1980s, when the first President Bush, with his administration, identified what they viewed to be the major domestic problem of that era. And that was that our children in the United States were lagging behind children across the world in terms of their education. Educational attainment was frustratingly slow. They issued a report, the Blue Ribbon Committee for the Bush administration, called A Nation at Risk, and they found what they called a rising tide of mediocrity in American schools. We were just simply failing to teach reading, writing, and arithmetic the way other nations could do it, and our children were not succeeding. So they proposed a whole bunch of different changes to American education. And 20 years went by, got into the 2005 to 2010 range, and nothing had changed. None of those recommendations had been implemented. So McKinsey and Company did a study. They looked into, well, did it make a difference? Does it matter? And their conclusion was, yes, it does matter. There was a persistent gap in academic achievement between children in the United States and their counterparts across the world, and that cost our economy $2.3 trillion in growth in the year 2008. Meaning, our children were less well-educated, less able, less competitive, less inventive, less innovative, less able to contribute to the economy, and our economy therefore grew less because of that. We should have had an economy, and I don't remember what the total GDP was in 2008, but it should have been $2.3 trillion higher, and it would have been if we'd educated our children better. All right, so what does that have to do with healthcare? Well, healthcare, like education, is mostly publicly funded. So when you spend $1 on healthcare, it's usually a tax dollar. And when you spend $1 on education, it's likewise usually a tax dollar. So if one is through a medical industrial complex far easier and greater and more adept at getting more dollars, then the other is naturally getting fewer because there's only 100% of the GDP. There's not more than 100%. So when you go from 11 or 12% to 18 and closing in now on 20% going to healthcare, then something suffers. This is the percent GDP going to education over the past decade, and you can see it's falling. This is during a time frame when the GDP going to healthcare is rising. Eventually, if we continue to spend more and more on healthcare, we will continue to become less and less productive as a society because we'll be less able to educate our children. And that's a part of the way that the wheels will fall off the economy. But it's not just that. You've heard people, I think it was Dr. Klein, refer to the social drivers or determinants of health, which go beyond what healthcare can actually do to preserve health and protect it, prevent health problems from occurring. One of the most important, if not the most important, social driver of health is education, as it turns out. The social determinants of health literature has the following to say about education and educational attainment. A better educated populace is a healthier society. It's a society with lives that are longer, so has to do with the longer life that we saw on the first slide. It's a society that has more healthy behaviors, better diets, less smoking, more exercise. Education drives that too. It's a society with fewer chronic illnesses, with less functional limitations, and a society with less disability. All of those things are true with a better educated society. So the more we drive through our dollars going to healthcare, the more we drive down the educational attainment of our populace, ironically, the more we spend on healthcare, the more we die younger. That is apparently the case, according to the social determinants of health literature. So we not only compete, healthcare not only competes with education for dollars at the public level, we also end up with a society that's both less educated, so less adept at creating new streams of revenue through productivity, and it's also a society that's less healthy and therefore more likely to fall apart. I think you can see from that it's a downward spiral. The more we drive money into healthcare, the more we risk our whole economy. This is not a sustainable situation. One of the things we at Common Sense Healthcare for Utah agree on is that we have to do a dramatic change, not an incremental change, because we are facing that kind of dramatic change when the wheels fall off the economy. We have to act now in order to prevent that from happening. So what we're seeking is a proposal to change how we do healthcare business that will reduce how much we spend as a percent of GDP on healthcare, while at the same time improving the quality of care and therefore improving the outcomes of care. Now, that doesn't sound possible. In fact, Dr. Klein repeatedly says you have to pay more to get a better quality care. That's kind of the mantra that he kept using. And what we're trying to say is, in fact, that's not true. You can, in fact, have a lower cost system that is better quality. In fact, those two are related. What you have before you in this slide comes from the economic analysis of our proposal from Common Sense Healthcare for Utah. We call our proposal Utah Cares. What will happen to the percent GDP going to healthcare once Utah Cares is implemented? Let's assume it passes in 2026 as a ballot measure. So it starts implementation in 2027, and then in the subsequent years is fully implemented. What our economic analysis suggests is that in the first year after implementation, the percent GDP in Utah going to healthcare will drop by 2%. And over the subsequent 5 years, it will drop by another 3%, or a total of 5%. There is no incremental proposal that has ever been discussed and determined in the United States that has ever said we can change how much we are devoting, how much of the GDP we're devoting to healthcare. This is a unique and different approach. So how can we do that? Well, first let's look at where we are right now. We have kind of an awkward, that's understating it. We have a very difficult situation for our patients, but a very lucrative situation for the medical industrial complex. On the left of this slide, you see that corporate profits are doing well. The first one is about hospitals, and I chose Intermountain as the example because they're, of course, hospitals that everybody here in Utah knows about. In the first 3 quarters of 2022, Intermountain recorded a net income or profit of $2.16 billion. If you then add on the presumptive fourth quarter, you'll get something close to $3 billion in profit for the year 2022. And you have to remember that in the year 22, about $30 billion total was spent on healthcare in Utah. So they are, in that one system, receiving as net profit 10% of everything that's spent on healthcare in the state of Utah. That's doing pretty well. United Health Group, the largest insurer and now one of the very largest corporations in the country, in 2023 had profits of $22.4 billion, which they reported was 11% up year over year from the previous year. Again, they're having great quarters. They're having, the bottom line's working well for them. And then there's a statement about the pharmaceutical industry, where pharmaceutical companies typically earn profits on average of about 14%, whereas companies that are not in the healthcare sector on average have profit margins closer to 8%. Again, profit is doing well for healthcare corporations. On the other hand, our patients in Utah are struggling. This is data that was published in the Salt Lake Tribune last fall. Almost 70% of Utahns had what was referred to as at least one healthcare affordability burden, which meant that they either had to forego buying health insurance because they couldn't afford it, or they had to forego buying care, again, because they couldn't afford it, or they couldn't buy a medication that was prescribed for them because they couldn't afford it, or they couldn't pay other household bills like electricity or rent or groceries because healthcare costs had robbed them of that discretionary income. 2/3 of Utahns were in that situation in the year 2023. When they were asked, Utahns almost universally said they're beginning to worry that they won't be able to afford health care in the near future. And finally, a national firm rating healthcare affordability across the country rated Utah as having an F, a failure grade. So while our corporations are making massive profits, our patients are having incredible difficulties financially trying to find a way to get the care that they need or their families need. It does us no good to come to CME and learn how to treat asthma and melanoma like we did this morning if when we write that prescription or we recommend that procedure, the patients simply say, I can't afford it. Meanwhile, in a measure I think that is as good as any about quality of care, comparing ours in the United States with the rest of the first world, we do very poorly, or at least can't be said to be doing better than mediocre. This is a measurement called avoidable death, or in past history it was called amenable mortality. What this basically is a measure of what the rate of death is in a country for conditions that are treatable with known clinical science. So they've eliminated from thinking about this deaths that medical care couldn't do a thing about, and instead focused on the ones where proper and timely health care could have made a difference and prevented the death. The United States, 2 bars, and the lighter blue colored bars are from the year 2000, and the darker ones are from 2016. Here's the US 2 bars over here on the far right. We started in 2000 from a point of amenable or avoidable death that was a rate higher than the rest of the first world. We improved, as did the rest of the first world, but we improved less than they did, and so we're falling further behind. We have a system that is, in the first world, least likely or least able to be able to prevent the deaths that we in clinical science know how to prevent, and we can't do it. As Dr. Moore said, I think it was him, we do the right thing about half the time. Meanwhile, as I've already mentioned, we are the most expensive healthcare system, and I'd argue that those are related. Poor quality care costs more. It's not the other way around. Higher quality care costs less, not more. So here we are. This is a per capita measure of healthcare costs. Again, bars that represent other first world countries with the US bar at the bottom. Our bar is divided into a yellow section and an orange section, whereas all the other countries are all a uniform color. And that's because most countries just simply raise taxes and spend those tax dollars on the health care in various ways. They're not all uniform in how they do that or how they arrange the financing. But it's publicly funded. In the United States, healthcare is primarily publicly funded as well. That yellow bar is the US public funds going into healthcare. I think Dr. Klein said that 50% of the money going into the healthcare system is government money or tax money. But it's actually more than that, because in addition to Medicare and Medicaid and the more visible healthcare programs that are funded through mostly state and federal money, there are tax policies that make it easier, or should we say less expensive, for an individual to get health insurance or health financing, if you will, from their workplace. Those tax policies involve a transfer of wealth, and basically a tax structure that supports the healthcare system, and that's public money too. So something closer to 2/3 of that $4.5 trillion, or about $3 trillion, is actually public money coming through our tax processes one way or another. We are, therefore, the most taxed citizens in the world for healthcare. We tax ourselves more than any other country. I need to reemphasize that, because it's commonly thought in the United States that somehow if you transfer or transform our system into something that's like another country's, that will result in a remarkable increase in cost, because it doesn't cost a lot more to do socialized medicine. Well, the socialized medical system in the UK costs about 1/3 of ours. It's not true, okay? Now, the other half of our bar is not public money. That orange section there is private out-of-pocket money. That comes from our private employers who are paying for a health benefit for employees and their dependents. And increasingly and more often, it's coming out of individual patient pockets. They pay part of the premium as well, but they also pay an increasing number of other things like co-insurance, co-payments, deductibles, et cetera, that come out of their pocket. The orange part of the bar is what the average patient thinks is healthcare costs. When they're talking about healthcare costs, they're seeing their premium taken out of their paycheck. They see how much it costs when they make a co-payment. They feel all of those things. They call that healthcare costs. And it is significant. It's bankrupting Americans. Half of the bankruptcies that occur in our country are driven by healthcare costs, and that's the orange bar. And that part of the equation in the United States is the part that's growing the fastest. And so it's pinching people's pockets, and it's why people have repeatedly said, including in the 2023 article I already mentioned, that they don't think they can afford health care. At least they may not be able to afford it right now, and they certainly don't think they can afford it next year or sometime soon in the future. This is what makes health care costs such a big issue among the electorate. This is a slide depicting the growth in deductibles as they rise over the recent time frame. This has to do with the policies that were enacted during the implementation of the Affordable Care Act, ironic name. Because while it is true that the Affordable Care Act required insurance companies to offer or guarantee issue of a premium, that is a true case. People could go on the website and buy a health insurance policy, perhaps for the first time. What it didn't rule out were all kinds of very creative ways of recovering costs from those patients, and one of those was the increasing use of deductibles. And deductibles grew dramatically after the Affordable Care Act was passed. They'd already started growing before that, but they certainly have grown a lot more since. We now have, let's say before the Affordable Care Act passed, the big issue was how many people in the United States are uninsured. And I think it was around the range of 40 million Americans. And that concern about uninsurance drove the passage of the Affordable Care Act. And it's true that fewer people are uninsured now. Maybe half as many are uninsured. I think it's around 20 million now. But what we haven't calculated or don't typically think about is that the person who can't afford their deductible or who can't pay their coinsurance, that person can't get the benefit of the health insurance that they've been paying a premium for, or their employer's been paying a premium for, because the insurance company is off the hook. If you don't meet your deductible, they don't pay anything. That makes that person functionally uninsured. That's a new term. And if you add the functionally uninsured to the really uninsured in the United States, it's already a bigger problem today than was true before the Affordable Care Act passed. So we at Common Sense Healthcare decided to try to look at these cost issues from the patient's perspective. We began by looking at the Utah Foundation report that they issue one about voters' mindsets every 4 years during presidential election years. And in 2020, they said that healthcare costs were the top issue in Utah voters. Now, if you look back in time over a number of years, almost 20 years of their reports, healthcare costs are either number one or somewhere in the top 5. Now, parenthetically, I may say that this year's report just barely came out and healthcare is not in the top 20. But that, I think, is because housing costs have suddenly bloomed as an issue, which, by the way, are not unrelated to healthcare costs. When you're paying essentially for healthcare what you would be usually in the history be paying for housing, you can see that sometimes you can't have both. 1/6 of the people who are without homes, that are homeless today in the United States, are there because of healthcare costs. It drove them out of their house. But regardless, again, hark back to that 2020 report. What did people say? What did the Utah Foundation find out? Well, they found out that premiums had risen over the previous decade by 40%, that deductibles had risen by 74%, and that Utahns were paying $2,800 per person, that's man, woman, and child, on average, for out-of-pocket costs, which made our state have the 8th highest out-of-pocket costs in the country. Before this report, we were used to thinking of Utah as a low healthcare cost state, maybe the lowest healthcare cost state. This was an eye-opener. Our out-of-pocket costs were ranked 8. Further in the Utah Foundation report that year, they found 429,000 Utahns in the year 2018 did not get health care that they needed because they could not afford it. They just came to your office or to the ER or wherever, needing care, obviously needing care, being prescribed care, but not able to afford the care, and therefore they didn't get it. We pushed this a little further. We went to the University of Utah and asked the Matheson Center for Healthcare Studies for help at looking at healthcare costs. They added a couple of facts. One is, for 30 years, Utah has had the second fastest growth rate in health expenditures in the country. Now that, again, is contrast to what we've typically been saying to ourselves about healthcare costs in Utah. And that at that rate of growth in healthcare expenditures, Utah's healthcare costs will double every decade. Now that, I suggest to you, is unsustainable. It gets back to why we at Common Sense Healthcare have decided we got to take a very dramatic step. We can't do incremental anymore. We need to actually offer something that will transform the way we do healthcare business. Because what we have right now, if we wait another 10, 15 years, the healthcare costs are going to double and then some. But how? This study, which is a little bit dated from back 20 years ago, gives us a hint. Each dot on this slide, and again, don't expect to read those dots, each dot represents a state in the United States of America, and there's a dot for the District of Columbia, so there are 51 dots. And they are displayed according to a quality of care index on that axis and the per capita cost for the care in their state on this axis. So the higher they are on the chart, the better the quality in the state, and the more to the left, the lower the cost. Utah, by the way, is right there. So on the high quality end and the low cost end. Well, there is a relationship between cost and quality according to this study. And that relationship is expressed by this regression analysis line right there. It is true that healthcare quality affects its cost, but it's exactly the opposite. It's what I've been telling you. Higher healthcare quality costs less. If you do the job right the first time, you spend less money on the patient thereafter. Good quality care costs less. That is our way out of this mess. We need to let physicians and nurses do the right thing for their patients, and then we'll be spending less. There are estimates out there about what the lack of quality costs us in the United States in terms of a total loss. That's called quality loss. Quality loss in the United States healthcare non-system ranges, according to various estimates, from $500 billion a year to $1 trillion a year. So that's getting to be real money in a $4.5 trillion health economy. Okay, we also need, so that's better care. I promised to talk about better care. I also promised to talk about simpler care. We also need to do simpler care, or simpler financing of care. The overall administrative costs and the way we do business in the United States is ridiculously high. This is putting the administrative cost in a per capita basis. So we spend, and this data dates to 2020, we spend $4,323 per person in the United States on administrative costs, on the administrative burden of just doing the way we do financing business. Whereas our neighbor to the north spends 1/4 of that. If you were to calculate that out over a population of 300 million people, you can see that we're, again, somewhere around the neighborhood of $500 billion lost to administrative waste. We need better care, and we need simpler care. Now, I want to go through an illustration of how we fail our patients, or how I should say the financing or business system fails our care providers. That's a better way of putting it. And this anecdote comes from Brent James, who he may be in the audience because he's speaking not next, but the final speaker of the afternoon. Brent James, it's a name you may know, was at Intermountain as a quality improvement officer for many years. And I took his course, and among the stories that were talked about was this one. And I've asked him if I could use these slides, and he's given me permission. So this dates to the 1990s. A family physician in Sanpete County at the IHC Community Hospital there felt that he was seeing something wrong with the care of pneumonia patients. He felt like they were becoming too sick and needed hospitalization too often and were dying too often. So he studied the problem and came up with a guideline about how to treat patients with community-acquired pneumonia. And he went to every one of the other physicians on the hospital staff and persuaded them to follow the guideline that he'd written. And then he went to the hospital administrator and got permission there and an agreement that the hospital would follow the guidelines. So it was implemented at the end of 1994, and in 1995, they took some measurements and compared them to the care and the experience before the guideline. So on your left, 1994, without the guideline, the percent of patients with pneumonia who were so sick they needed admission was about 40%, and it dropped by about 25% after implementation. The average length of stay for those who had to be hospitalized dropped from 6 days to 4 days. That's about a 33% drop. the time it took to get a patient presenting with what turned out to be pneumonia to antibiotic treatment went from 2 hours to 1.5 hours. That's only about a half-hour change. But the average cost per case dropped in half. This is a great outcome, a wonderful experience, and something that Brent told us that the hospital decided to continue on with. But that was despite the reimbursement or the financing that was experienced with this experiment in better care. So you see here a yellow line, which is the actual cost of the care that was delivered for pneumonia. And the green line is the expected cost based on that yellow line. So you can see they track each other before the guideline was implemented, where that white vertical line is. Then the expected cost takes off in the direction that was indicated prior to the guideline implementation. The yellow line drops off, and as I said, it dropped to half of what it had been before. The blue line is what the hospital actually got as reimbursement from the various payers. And it fell too, just like the cost per case of care did, but it fell more than the actual drop in cost. So the hospital took a financial hit for doing the right thing for pneumonia patients. Now, I'd like you to do a thought experiment and ask yourself, if you were the administrator of a for-profit hospital in Utah and you saw that data, what would you do? What's your next quarterly statement going to look like if you keep finding ways of improving the care that improves the patient outcome, but means that you take a financial hit? We have a system that rewards these administrators for making sales, and in this case, the sales are for ICU patients who are sick with pneumonia, and instead of treating them so that they don't need that care and then that sale is not made, I suggest to you that many hospital administrators would probably not do this. Brent assured us that this hospital continued to make that effort for these patients. But I think this tells us a little bit about what is wrong at the heart of the American healthcare system. We are oriented around how to make the most money possible, and we do that very well. There is no more profitable healthcare, and I keep using the word non-system, in the entire world than ours is. People make a lot of money the way we do business now, but that is not the way you take care of patients. What we are proposing at Common Sense Healthcare for Utah is a much changed approach to the business of healthcare. We are proposing nonprofit public health financing for all medically necessary care for all residents of the state. We want it to be universal so that you, as you take care of people, are not worried about whether they can actually fill the prescription, because they will be able to, generally, be able to fill the prescription. We want them to be able to get the care that is needed, that you identify as their needed care. We want not only all people to have it, but all kinds of medically necessary care to be covered within that. That's what we mean by universal and comprehensive. And we want to virtually eliminate the out-of-pocket costs. That whole orange bar has to be replaced with a different way of financing care. We propose one trust fund, one private, nonprofit trust fund to pay for all the necessary care for our residents. Very simple billing. For hospitals, no billing. Hospitals will be paid on a negotiated operating budget basis. What they need to meet the needs of care in their community is what they will get as a negotiated budget, and it will be just paid. There's no billing for that. Simple billing for physicians and other practitioners out there. Simplified, you send in the bill with an email and it gets paid that week. That's what we're proposing. Patients will be free to choose any physician, any provider of care, anywhere in the state of Utah. There would be one panel. Everybody who opts in will be part of the panel. And every patient can just make a choice If they go to see one family doc and decide they're not sure they got heard, they can go choose to see another one. So patients choosing their source of care, I think, automatically changes the focus to what the patient needs and who the patient is, and serving that patient as best as possible. Our economists predicted a $16 billion per year saving for doing business that way over the previous way of doing business on approximately a $40 billion budget projected for year of implementation. That will make it possible for physicians to save a lot of administrative hassle and waste of time, or click time, as we heard earlier today, and devote that to patient care if that's what they choose to do, or to family time, or whatever. We estimate about a 10% effective increase in the physician workforce just from making this one simple change. We are currently researching the best way of raising the money necessary to replace the orange bar, the out-of-pocket costs, the costs to the employer and to the individuals. We hope to soon be able to add that to the presentation. But we will find a way that is comprehensive, that's progressive, that's stable over time in the economy so that it doesn't lag behind the needs of the healthcare system. That's our basic outline of our proposal. As was already mentioned, I've written some books. If you want more information about where a lot of this data comes from, it's in the books. I've also produced a movie called Healing Us, and copies of that DVD are available also out front. Please come and talk with us. We can't do this. I mean, a ballot initiative is a gigantic enterprise. It's a very expensive enterprise. It takes a lot of effort and it takes a lot of people. We're here to tell you about what we're about, but we're also here to try to get you to come and join up with us. Learn what you can do to contribute to this process, and let's change how we do healthcare business in Utah. Thank you.
So a question, so I think you're suggesting a single payer system that is on a state level, is that correct?
That's right.
And I was just maybe comment on what your thought is on a federal level versus a state level, a single payer system, and if this has ever been done before in other states.
Okay, first, federal versus state. The federal level proposal would be something like Medicare for all. And that, of course, has been discussed, particularly by Bernie Sanders in his runs for the presidency a couple of times. If it were an imminently passable thing, Medicare for all, I don't think we would have gotten together and worked hard at the state level to make our proposal. But it's not a thing. It's not going to pass. Even if it were somehow to pass the House and the Senate, President Biden has articulated clearly that he would not sign it. So for the foreseeable future, it's not possible. Therefore, this is a political decision, not a policy decision. We're working at the state level because we can. We actually have ballot initiatives where we can bypass the power of the medical industrial complex at the legislature and put it to the people. That's why we're doing it at the state level. I forgot what the other question was. Any other states? Yes. State-based universal health care has been on the ballot in at least a dozen states, and it's in another dozen states' legislatures. No one's ever passed it. I want to quickly add that. But it's an active consideration in, I think, 18 states right now. Sooner or later, there is going to be a state that breaks through that will make this happen. I'd just like it to be Utah to lead the way. Yes?
I actually had a couple of observations, and then at the end of this, a question. So the first was, regarding the out-of-pocket insurance costs, out of working age Utahns, especially those who are self-employed, it's my impression that the volume of those employed by small business at least used to outnumber those that are employed by corporations. And that, therefore, if you look at the values that you presented today, and it would strike me that they're actually worse than what you presented, because it would seem that if you took the costs that the average employed individual, again, looking at more self-employed than corporately employed, that their costs are actually worse out of pocket when you compare those to these numbers that would otherwise be skewed by the corporate and public health costs that are realized by a corporate employed person who might only pay a third out of pocket and their employer pay 2/3, or say somebody who's on Medicare whose costs are much more sharply limited than somebody who might, like myself with a small business. I mean, I had a family of 3, and my maximum out of pocket 5 years ago was $18,000, and it's only gone up since then.
You're absolutely right. There are plans out there for especially larger employers. Boy, I need to learn how to not knock this over. Larger employers, especially public employers, where those employees and their dependents are favored by the current way we do business. And those who are trying to be entrepreneurial or start up a new business or work for a small employer, which is supposed to be sort of part of the American way of life, they're not getting it. So this is called job lock often. People who have ideas and they'd like to start a business don't because they need the health benefits. You're right about that.
It stifles innovation. And then the second observation, and there's a question with this one as well, and that is that I personally believe that stable housing must occur for positive and reasonable health care outcomes. But if you have housing costs that are rapidly increasing and along this fairly steep trajectory, especially in recent times, not just by inflation, but also by mandatory returns, like 30% or even higher, from taxpayer-assisted hedge funds purchasing primary housing and then turning around and either controlling enough of the rental marketplace that now you can have rents set at a high enough level that 10%, 8%, whatever it is, can't afford housing in a community, and each year it seems like it increases, or the same with the costs for purchasing supplies, or is setting the cost for sales for existing housing. So as part of this initiative, is this something that has been looked at as well?
Well, you've articulated the reason that I think why the Utah Foundation found that housing costs was a higher anxiety, if you will, than healthcare costs in the current election year. This is what they recently published. I think you've articulated it very well. I would argue that the healthcare costs have been higher and growing faster for longer than the housing costs, and they still remain a major impediment in any family establishing an economy for itself that includes housing, food, clothing, and other things that are necessaries of life. We need to get that orange bar out of our employers' way, and we need to get that orange bar out of families' way. If we were to do that, the housing situation would improve dramatically.
Anyway, thank you.
Over here.
Dr. Jarvis, thank you so much for coming, and thank you for being a thinker and looking for solutions. I can't endorse common sense. I don't know enough now to say if that is the right solution in my world, but I do appreciate it. I look forward to some lively discussions for the next several days with your colleagues. And I think I would recommend to our society that we consider having this discussion next year. If this is a ballot initiative next year, maybe we look for a point-counterpoint discussion with this also. Maybe just 2 quick questions, and I'll sit down. Number 1, how do you define resident of Utah? And number 2, what do you see as the 2 major barriers for this to pass?
Thank you. So, resident of Utah, for purposes of Utah Cares, in order to simplify the ballot itself and not create more wording ourselves, we will look for the broadest definition that already exists in Utah statutes. And we'll just adopt that by reference, whatever that is. And I don't know what it is. But we'll look for the broadest definitions just simply because that's one less thing we have to write about. Okay, another question he's asked is, if Utah becomes the breakthrough state and we pass universal health care, state-based universal health care, won't it become a magnet, meaning draw people here? Well, I think the answer is yes. Employers all across the country would see that our employers here no longer have to find a health benefit for their employees and dependents. They, in fact, will be able to offload the entire process. Wages will go up because what currently is spent on healthcare is drawn directly out of wages. So yeah, I think we will end up being a
This
draw.
is a lively discussion I'm looking forward to, but won't it also be a magnet to those who are unemployable yet will need medical services
So
and
people,
cannot obtain them in another state?
So people move around and go to places because they have the economic wherewithal to do that. And then if they come to Utah, they will bring with them that economic wherewithal. But I think what you're forgetting is, if we get it through as a red state, what do you think all the blue states out there are going to want to try to do? This will be replicated everywhere. We're not going to have to long-term worry about this, and I can see. I have 30 seconds for one question.
Joe, I've been through this twice, once in Michigan in the 80s, where we had 10,000 people a month moving in, 20% from Texas, that were uninsured because there was unlimited health care, and it bankrupted the system in Michigan. Two of my friends tried to immigrate to New Zealand last year. New Zealand has new regulations. You cannot immigrate if you're over 55, if you are obese, or if you have kidney disease. Because so many Pacific Islanders were moving in for free health care, it was bankrupting the system. Number two, as Brent James said 3 years ago in this meeting, IHC's too big. You can't stop us.
Well, we hope we can outvote them, if not stop them. And yes, I get your point that too many people who are bringing really unfunded healthcare needs might be a problem. But I would argue again, we're not going to be standing on our own with this. It's not going to be the case that Utah alone will be doing this. If we pass it, so will other states. Thank you very much.
Thank you. So Dr. Jarvis has books outside that he will be signing until 4 o'clock. Meanwhile, we will have Michelle McComber come and speak